Welcome everyone to this patient-focused webinar. I'm Mike Sievers from InsightTech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. Again, please be patient as we take a few minutes to allow everyone to get signed on. We will be beginning the presentation shortly. Okay, it looks like we have a good number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We're very fortunate to be hearing from Dr. Vibhor Krishna and Dr. Daniel Roque from the University of North Carolina at Chapel Hill, as they discuss treatment options for essential tremor, providing an overview of focused ultrasound treatment. As questions arise during the presentation, please utilize the Q&A button located on the bottom of your screen. We will have time after the presentation to answer the questions that are asked within the chat. Let me begin by introducing you to today's presenters, Dr. Krishna and Dr. Roque. Dr. Krishna is a board-certified neurosurgeon with expertise in functional neurosurgery and neuromodulation. Dr. Krishna treats patients with movement disorders, including essential tremor, Parkinson's disease, and dystonia. He's an early adopter of focused ultrasound technology and is considered a thought leader in the field. As a surgeon scientist, he focuses on research to optimize the focused ultrasound technique, improving patient outcomes. Dr. Roque is a board-certified neurologist and movement disorder specialist with specific expertise diagnosing and treating multiple tremor syndromes. His clinical and research focus is on the improvement of tremors through both traditional and innovative methods, seeking out quality of life initiatives for patients with movement disorders. He serves on multiple regional and national forums aimed at improving outcomes for tremor management. Welcome, Dr. Krishna and Dr. Roque, and thank you for presenting this effort. The floor is yours.
Thank you, Mike. I really appreciate the kind introduction, and thanks to our participants for logging in. This is a part 4 in a series of webinars that we have presented over the last several months. And the goal of these webinars was to create an educational series to be able to connect with patients and family members and loved ones who are interested to know more about essential tremor and focused ultrasound. And as we conceived these webinars, we initially talked about, diagnosis of essential tremor, what treatments do exist, including therapy, occupational therapy, to be able to overcome some of the challenges that come with tremor in patients with essential tremor. Medications, different medications, and what to expect in terms of tremor reduction, the different dosage and any side effects that come with it, and the surgical options for patients with tremors. In general, these include deep brain stimulation surgery and focused ultrasound ablation surgery. And then we went into the details of all these, and the thought was that the last webinar we would summarize the learnings from all of the webinars that we have done so far. And so the way we organized this webinar is, in the first part, we would give an overview of what different webinars included, and then we talk about, my partner, Dr. Roque, and I go over in little details as to the highlights or the key take-home messages for each one of the webinars. And so And then we want to keep it interactive. We had last time great interest where folks asked a bunch of questions, and we loved those questions, and it was very informative to us, as well as other participants as to what folks were thinking and what questions come up. And so what we want to do is go over some of the aspects of focused ultrasound technology. And what I would do is come to you through this video that goes into the details of the focused ultrasound technology. And then I'll share the floor with my partner, Dr. Roque, and he will go over in detail about essential tremor and the different treatment options that are out there. So, Mike, can you please confirm that you're able to see my screen?
Yep, it looks good.
Great.
And Dr. Roque was able to join us as well.
Yes. Welcome, Dr. Roque. And so we were just getting started and summarize the findings. And we wanted to share this informational video that kind of goes through the workflow of focused ultrasound. So as you all know, focused ultrasound is FDA approved to treat two conditions, essential tremor and Parkinson's disease. We talked about that you don't require anesthesia administration for this treatment. And this can be done outpatient. And so patients go home the same day after surgery. As we know that this treatment does not involve any incisions, and the results of the treatment are right away. And so at the end of the day, you receive benefit from the treatment. The treatment is done inside the MRI scanner. You can see that this big donut is where the MRI is at. And patients receive this head frame that allows us to keep the head steady during the treatment. And the ultrasound transducer, which is shown here highlighting in green, is then placed on head. And the space between the transducer and the head is filled with degassed water. And patients are lying comfortably and padded well during the treatment, which usually lasts between 1 to 2 hours of the treatment. And to give you a broad overview, there are these tiny little ultrasound elements. 1,024 of these elements emit the ultrasound beams. By itself, each one of these beams is harmless, but when 1,000 of these combine together in a single spot, then the energy is enough to achieve a precise ablation in the brain. So one good way of thinking about this is, when you have a lens that can focus all the beams or the light energy that's coming out of the sun, then you can use that lens to focus on a single spot and be able to increase the temperature. In a similar way with ultrasound, you could do that. And this is a little bit of technical detail, but it's important that initially what we do is we look at delivering very small dose of ultrasound here, shown in power and duration. And so this small dose, what it does is it temporarily increases the temperature ever so slightly, and that allows us to do testing on the patients in real time to make sure that the patients are not having side effects and the treatment effects are desirable. So if patients are having surgery for essential tremor, we can test tremor in real time and make sure that patients' tremors are improving. And once we confirm that the spot that we are treating is safe and that we are not having any side effects, so in this video is showing live testing, as you can see. And once we confirm that patients are not having side effects and their symptoms are improving, then we can deliver ultrasound energy at a higher level that allows us to then permanently ablate that spot in the brain that we were treating, so that patients can have long-term improvement in their symptoms. And so initial testing at low energy, and then you increase the temperature to be able to then permanently ablate the area causing tremors and improve patient symptoms. And this treatment now is very widely available, and the patients undergo this treatment and go home the same day after surgery and can achieve excellent reduction in their tremors and be able to do things that they enjoy doing in their life. And so that's the eventual goal, to be able to connect patients with what they enjoy doing. And so this is the brief overview of the treatment. And then what I'll do is I'll hand over the floor to my partner, Dr. Roque, who has a very informative presentation going over the summary or the take-home messages, if you will, of each one of the webinars that we presented. And then we would keep it interactive, and we'll keep taking questions, and then we'd love to answer all your questions. So Dr. Roque, the floor is yours.
Thank you very much. Are you able to hear me?
Sounds good, Dr. Roque.
Thank you very much. Give me one moment to pull this up and then hopefully get us. Apologies, it's taking just a moment. So while it's getting started, I want to just mention out, I appreciate everyone who's joined in on the multiple different webinars. And as Dr. Krishna noted, the goal is going to be for today to try and provide a meaningful overview of the information we've provided at previous webinars, but hopefully some evolving take-home points from it that weren't explicitly stated previously, but hopefully are quite useful to anyone and everyone who watches the webinars. So here we go. Okay, I am hopeful that you can now see the presentation.
Yes, we can.
Thank you so much for confirming. Okay, so the idea of going from minimal efforts to specifically trying to address tremor, meaning any opportunities to improve tremor, but without doing much more than perhaps conservative opportunities, to what we otherwise refer to these days as minimally invasive opportunities to improve your tremor. We'll try to cover it all and cover it all in a meaningful, comprehensive, but also concise fashion. My usual disclosures here, but the goals for today's talk. So we'll start off with the most important feature here. We're talking about essential tremor. We're talking about the management of essential tremor. So we'll solidify that diagnosis one more time, discuss the conservative options, medication options. Then, as I already alluded to, the minimally invasive opportunities, surgical options for the treatment of tremor with a focus on focused ultrasound. Understand the risks and side effects associated with these surgeries, and then finish off by discussing what our team does at UNC. So how to tell tremors apart being a meaningful and important first step. We do have this long history in neurology of having difficulty separating different tremor types from each other, but ultimately feeling that we have three major categories, but they're not all inclusive. Trying to get that diagnosis right, getting it correct, distinguishing tremor types being extremely crucial to your treatment options, because invariably those treatment options vary depending on the tremor type that you are experiencing. Rest tremor being among those, as we described before, totally being at rest, experiencing the tremor only in those scenarios. There is a re-emergent tremor type that evolves from that as you hold a posture. Seconds to minutes later, it evolves. Conditions like dystonia that are certainly a different movement disorder that we see, where there are signals from the brain indicating that you should hold a posture, and it looks tremulous as your body tries to force that posture, thanks to that erratic signal. And then tremor caused by medication. We have the new diagnostic criteria available to us, where it tells us that essential tremor needs to start with tremor in both arms with action. It could include tremor in other locations, but that's not required. And certainly we see a traditional evolution of tremor developing in places outside of the arms, and that the arm tremor should be present for at least 3 years before you can categorize the tremor as essential tremor. And then I've shown this table before. What do we mean by the different kinds of action tremors? Postural tremor and intention tremor are both types of tremors that that we see in essential tremor. They're both considered action tremors. One occurs while you hold a fixed position, and then the other is as you are moving toward a targeted area or a targeted activity. The kinds of tremors you see assessed in different neurology clinics, and certainly if you are visiting with a movement disorder specialist, is the idea of extension tremor, or postural tremor with extension, postural tremor with wing beating, or so stated because you hold your arms, your elbows out at the sides, and note tremor that happens at the hands, but you might even see some of it extending into the rest of the arm in that specific posture. And as I already mentioned, intention, we measure that in clinic through the finger testing, so finger nose testing, have you touch the physician's finger and then touch your nose and go back and forth. Oftentimes when tremor is bad enough, we will have you touch your chin so that it doesn't end up hurting yourself in the process of doing this maneuver. Then there is rest tremor. And again, the importance here of knowing rest tremor can occur in folks who have essential tremor without meaning that you are suffering additionally from Parkinson's disease. This often manifests in the manner that I was describing earlier, in a re-emergent fashion. As you hold that posture, it grows, a tremor amplitude, the size of it grows over several seconds to even minutes at a time. And that is, in fact, the rest tremor pushing through your posture as opposed to your primary postural tremor. This can happen in a quarter of people who have essential tremor, again, without necessarily requiring a diagnosis or indicating that you're going to develop Parkinson's disease. Although that said, a DAT scan, which is not unlike the image I'm showing you here on the right, is a tool that some physicians will use in the setting of confusing tremor in order to parse out whether a person may also be suffering from or wholly may be suffering from Parkinson's disease as opposed to essential tremor. Where this becomes crucial, even if it's rest tremor in essential tremor, the treatment for that rest tremor is quite different than what we otherwise would use in terms of the traditional approaches or medications toward managing rest tremor. The natural evolution of tremor, this is an important point, it progresses. And the only thing we don't fully understand yet in terms of the inherent progression itself is what are those variables that are responsible for the changes in the progression, whether it's a speedy progression over years or a very slow progression over decades, or it may seem as though there's a pause in progression for decades before progression occurs. These are factors we just don't understand yet, despite the fact that we know progression in some way, shape, or form is almost rule if you follow someone over their lifetime. And the same thing happens with spreading of the tremor. So instead of only being strictly in the hands, as I mentioned earlier, it is plenty the case that we see folks who have head tremor, neck tremor, facial tremor, voice tremor, tremor in the trunk, tremor in the legs. And that spreading, similarly, we don't understand why, what are those variables that lead to the progression. But again, you can see that. And a really key takeaway from all this as well is for anyone who knows of your family history of tremor, you'll probably notice that everyone has a different way of presenting with their tremor. So no two folks, even in the same family, will necessarily have the same syndrome or the same appearance in their lifetime with their essential tremor. So in terms of finding ways to improve tremor, the traditional approaches here is that we're looking at symptomatic management. At the end of the day, unfortunately, we don't have any cures available for essential tremor. But increasingly, we have more and more options available to us. And certainly things like the surgical options enhance that portfolio of opportunities that we have for patients. The best suppression depends at least on the tremor type. So meaning you have to know what kind of tremor you're dealing with to know how successful a given treatment is going to be for a given patient. And none of the medications that are currently available on the market were designed for tremor. And this is a really key, crucial point to take away as well. We use them, they're FDA approved in several instances, but nonetheless, they weren't designed for tremor control. So let's start with that breadth of opportunities. This starts with occupational therapy, something that's not medication, not surgery, It's a chance for you to work with a therapist who is otherwise specialized in helping you regain function where you may be losing it, as related to your tremor. There has been a lot of opportunity and effort made towards studying how to enhance tremor patients' lives, and there's quite a few activities have been reported to be useful to clients, and you'll note a few of them that I've mentioned here. And again, tremor type being very important to knowing how your therapist is going to guide your recommendations. If you recall, for those who have been here before, weight-based therapy will be a bit more useful for postural tremor than intention tremor, especially if you know how to redistribute that weight, as opposed to having just a uniformly heavy glove or a uniformly heavy brace to wear. Just knowing how to distribute that weight based on which activity you want to perform with the hand can be quite useful. This can include gloves, as I already alluded to. There are braces that are specific for this, even bracelets. There are utensils, and whether that be writing utensils, eating utensils that are heavier, just to help you navigate the activity in question despite the tremor. Then there is so-called adaptive equipment. So this is an opportunity to not specifically reduce the tremor, but despite the tremor, get you to feel more independent with the activities you're performing thanks to the equipment. So this is where gyroscopic utensils, like the one imaged here, would work against your tremor in order to stabilize the head of the spoon or the fork that you're utilizing. In the case of the adaptive equipment for the mouse, despite the tremor shaking the mouse, it will sort of dampen the signal that ultimately gets to the computer. So again, just ways to do this. Intention tremor here will be more often improved than postural tremor, since there's an active portion to the activity you're performing instead of just holding a posture. Then there are medications. We talk about the different first-line therapies. We have beta blockers in the form of propranolol usually, where it could be useful to reduce tremor. It could also be useful to assist with reducing anxiety, reducing blood pressure, but it's risky if you do have known COPD or asthma, and otherwise might induce exercise intolerance, meaning that as you perform, especially cardio, it could feel as though you're not able to keep that endurance as a result of feeling short of breath. Primidone is the next medication that we talk about as first-line options. Both of these are often considered equally, and in fact are not infrequently placed together to treat tremor. It is originally an anti-seizure medication, and it has a very long effect time where it's at least 24 to 48 hours. So it could be dosed just once a day and still be quite useful, but it has sedating properties as an anti-seizure medication. Then there's the second line medications that we see more often useful. I forgot to mention that postural tremor would be better treated by propranolol and primidone, but intention tremor perhaps is a bit more improved by medications like Topamax or similar meds to it. Again, anti-seizure medication, where it could be useful if you happen to have a history of migraines in addition, but it may be more useful, again, toward reaching for items or as you actively perform activities as opposed to holding postures. The main difficulties here for folks are going to be sedation, word finding difficulties even without sedation, and then kidney stones if you don't stay well hydrated. The research that available on the medications shows us that we can get up to a 70% tremor reduction, but often this is described as temporary as the syndrome itself progresses. Nonetheless, the highest rate of success comes mostly from combining the two first-line therapies. The main point when you look at the research about topiramate or Topamax is that physicians will see most of that improvement, and perhaps more so than patients appreciate, but for some folks, they can really tell a difference. It's why we have it available to us, and certainly why folks can choose to continue to utilize it into the future. Other therapies that are used out there are just not shown to be quite useful. So what's the best practice? Keeping all these non-surgical options in mind, a combined approach, there's actually a bit of data that would suggest if you use medication together with the occupational therapy opportunities, this is superior to medication alone or occupational therapy interventions alone. So again, if you want to round out your opportunities pre-surgically, this is the way to optimize it in truth. So finding a therapist who is comfortable with managing tremor would be crucial. So when all this fails, how do we take those next steps? There are certainly surgical options available to us, and FDA approved. There are three. The first is the traditional thalamotomy. Not unlike what Dr. Krishna was alluding to here, there's a specific piece of the brain, the ventral intermediate nucleus, VIM nucleus of the thalamus. This is a place where we are aiming to, in the case of the traditional thalamotomy, burn this area of the brain, but by accessing the brain through the skull. This is certainly available, but have been largely abandoned in favor of less invasive opportunities. Deep brain stimulation surgery would be in similar vein, that you have to access the skull, get through the skull to implant these wires into the brain, into the same spot of interest. That doesn't change throughout these surgeries. And you do have to have those wires, of course, connected to a pacemaker to drive the electrical stimulation. And all this is under the skin, but is certainly considered minimally invasive, but compared to other brain surgeries, but still you have to get through the skull. And then in the case of MRI-guided focused ultrasound ablation, you never have to open the skull to access this portion, and you can still heat, like in the traditional thalamotomies, you can still heat that portion of the brain and do it in a smaller, more precise fashion, and with greater accuracy than we had in the past. So you've seen this image here. So what do we aim to do? As you've heard, we're trying to burn this small, very precise lesion or hole in the same recommended location, the ventral intermediate nucleus of the thalamus, VIM nucleus of the thalamus. We're honing in those multiple high-intensity ultrasound beams to heat that one spot of interest. And you have to be in an MRI scanner, in and out of an MRI scanner, to see the progression, see the progress that we're making as you come in and out of the scanner. You are awake, your head is shaven. And for this to be a successful procedure, we really feel that it's necessary to test tremor coming in and out of the scanner multiple times, check for the tremor changes, check for side effects as we heat up the brain, even before we burn anything. But certainly after we produce the ablation or the burning component. And a really crucial piece here that comes up time and again in these questions regarding the procedure is, can we use sedation, especially for folks who might be otherwise claustrophobic? Any sedation can truly negatively impact the results we can have from surgery. And this is a really key and crucial portion. We really avoid sedation in just about any way, shape, or form, because in doing so, we're really placing ourselves in a predicament where we might believe the tremor is better without having totally ablated the correct area of interest. Or perhaps we start to appreciate a side effect that's more side effect from medication as opposed to a side effect from ablation, and then we abort the surgery earlier as a result of this. So you can see that because that testing is so crucial, it could be quite detrimental if we attempt to sedate anyone. The head frame, as you've already seen in one of those images and videos, it's at these 4 points that we're attaching this head frame so that this could allow your head to be fixed on the scanner bed, the MRI scanner bed. And you've seen some images of this here, where you see the dome in question, where it has the ultrasound array, and then this bladder that's placed around the person's head, where water can cool between your head and the dome in an effort to keep your head cool as we do this heating procedure. And I'm not going to play this video. Well, maybe I will actually. So just so you can see the whole purpose and point here, we do want to perform these test maneuvers in and out of the scanner. If you are asleep for this, or if we try to wake you up from sleep, we're just placing ourselves at risk that we don't see the tremor in its full potential, that we don't see the results of ablation in its full potential from any one of those points there. Okay. So we talk also about an important feature that Dr. Krishna mentioned, heating before burning. So meaning higher temperature than usual in your own temperature so that we can start heating a piece of the brain, but we're not quite at the temperature that's going to cause you to have a burnt lesion or a burnt area. Already we can start to see if it's in the right place. We can already see some improvements in the tremor, but we might even catch some early side effects that could tell us this is not the right place where we want to burn the lesion. We want to move into a different direction, away from where we know those brain fibers may be affected because we are heating them up. The MRI scans are completed several times throughout the procedure, both with a heating process, but sometimes just so that we can get a good picture of where so far we've created a lesion or created that burnt area, and see how the tissue might be behaving instead of just information about temperature. What do we know about the benefits of going through focused ultrasound? These are some of the earliest, but still nonetheless very important to speak of results. We could see easily a 50% improvement in tremor scale scores for patients who underwent ultrasound compared to those who did not undergo ultrasound procedures. And at 12 months, there is a reduction in the number of those folks who continue to have the same level of benefit, but nonetheless, it's still a high percentage. The quality of life and disability scale scores also go in line with these tremor improvements. So like the visible tremor changes are very much in line with quality improvement. At 2 years, so we want to talk a little bit about longevity here, the disability scores still are significantly and dramatically improved. And you can see that if you just follow one of these bar graphs over the course of that time frame, starting before surgery at the very left and ending 2 years later. About 30, like I said, 40% of folks at that point in time are showing a less than 50% improvement at 2 years, excuse me. And you can kind of see that case by case here as folks over the 2 years are losing some of the benefits. So we do know that this could potentially last longer under the right circumstances, and efforts to really try to, sorry, I'm gonna come back here, efforts to try and increase the longevity of this and understand factors important in increasing the longevity of this procedure are both under publication and as well as underway to do this in as systemic a fashion as possible, so that we all understand better ways to improve the outcomes of this procedure for the long haul. Side effect wise, these are, again, using some early signs. Our earliest experience with the procedure would suggest that during the procedure, you can actually experience a different set of side effects as compared to just because you burnt an area. Dizziness comes up, and often in the form of feeling as though you're spinning inside of the MRI scanner. You can have nausea, and in cases where you feel like you're going to vomit, these are cases where we have to pull you out of the scanner quickly to be able to ensure that we do so safely. Headache can happen, as well as these flushing sensation or warmth over the scalp, despite the cold water being run over your head. And then tingling and numbness in different parts of the body as well. That's just during the process of being in the procedure. After the procedure is over, you'll see a lot of different numbers here, but this all boils down to a couple of important concepts. Around the area of interest are areas where there are important nerve fibers for strength, for sensation, for balance and coordination, and all of that goes to say as well for speech production and speech, like understanding your speech as well. Because of that fact, risks will be, because you burnt an area of the brain, could be weakness, could be loss of sensation, could be balance changes. And alongside those, any one of those can lead to speech issues as well. And so you'll see those different numbers pop up here, where mild symptoms are going to be the most common scenario. And then if you follow folks over time, 3 months and 12 months out, the balance issues, which is what we refer to as ataxia, you could see it perhaps as many as a third of people who undergo the procedure in those first 3 months. But that drops down by at least a third over the course of a year. The sensation abnormalities, the numbers these days are much better than the current than's published here, but nonetheless, we see that drop off as well over time. But difficulty with speech, weakness of a particular limb, arm or leg, these are things that traditionally do improve significantly over the course of that first year. Ataxia perhaps being, or balance or coordination issues being the most prevalent, perhaps still to this day. So all of this is important information to lead to the context for why the current FDA approval for focused ultrasound is such that we can only perform this on one side of the brain at a time. though we are allowed to do this on both sides, given a 9-month minimum time frame between procedures. So we know from the traditional thalamotomies, the ones that are technically still FDA approved but have been largely abandoned by most centers, is that if you perform this, if you burn a hole on both sides of the brain, the risk of speech impairment, of balance and coordination difficulties, even pain, numbness, tingling, these are things that can really be enhanced. These side effects can be enhanced, which of course we don't want. And so this is what led to some of the earliest recommendations only for a one-sided procedure. But it's certainly been discovered that we could, as long as that first side went well, we could then subsequently head over to the opposite side of the brain and provide a second procedure quite safely with what seems to be otherwise similar rates of side effects as you would otherwise get from one procedure alone. So, and perhaps that's because we're being selective, that if you get those bad, any of those side effects that stay with you over the course of the 9-12 month time frame, we're saying that it may not be a good idea to risk this by going to the opposite side. Oh, I got ahead of myself there. Okay, I'm going to wrap up with a thought here, and this is largely because of the sheer number of questions we get in clinic, but we also get in these webinars. Often folks are asking us to compare a focused ultrasound to DBS, since these are the most available procedures out in the community and in clinical practice. I tried to provide two separate tables with a little bit of context on the high order points. This is far from a comprehensive set of tables, but hopefully useful so that you can see how the two procedures actually have some in common. Enough that it's worth noting that we're aiming for the same benefits, right? Tremor reduction, none of these are cures. There are opportunities to improve your quality of life through tremor improvement. We just go about them in different manners. You have to shave the head for both procedures. There is a frame involved in both procedures, with a little caveat on DBS. There are quote unquote frameless systems, which still require a kind of head frame in order to proceed with the implantation, with the wire implantation. But ultimately, there's some kind of frame involved. For MRI scans, there'll be a bit of a discrepancy here just because of the nature of the procedure for focused ultrasound. You're in and out of the MRI scanner far more. And yes, there is still a preoperative MRI, one to plan out your surgery, which is true in DBS. But of course, just during the procedure, this is all guided by MRI for focused ultrasound and not for DBS. In the case of brain targets, I've already alluded to this. It's the same target in both procedures. Where things start to get a bit more discrepant is going to be in this nature here, the focused ultrasound procedure. Each procedure is going to be shorter, and different centers will have different experiences on exactly how short, but it will be shorter than even performing deep brain stimulation surgery on one side. In the case of doing a bilateral procedure, in the case of focused ultrasound, and technically in the case of DBS, the FDA approvals are to do one side at a time. The practical on the deep brain stimulation surgery side, though, is different centers have different success rates with performing both sides at the same time, and both wires would get connected to one battery. So that is an option that centers can and often, not infrequently, I should say, do use. In the case of hardware that's being implanted, there is none for focused ultrasound. Perhaps this is inherently the biggest pull to consider focused ultrasound. Whereas, of course, the deep brain stimulation surgery hardware needs to be implanted to have the results that one is looking for from the procedure. And then the question that always arises, what if tremor returns in the case of each procedure? In the case of focused ultrasound, it may be possible to repeat the procedure, and not everyone will be a candidate for that, but you could certainly be evaluated for that consideration. In the case of deep brain stimulation surgery, it may require just a change in stimulation settings, but that also may not be enough. It just depends on the certain circumstances. But it is certainly an option, and then at that point, if that was possible, then hopefully we would avoid another surgery. So all that, let's summarize the information into hopefully one last digestible piece. Essential tremor ultimately is a syndrome. It requires a keen eye, good history to distinguish from other tremor syndromes, especially since you are allowed to have more than one tremor condition or more than one kind of tremor. The treatment for tremor that's available should be tailored to your specific tremor type, especially in the face of having no cure for the essential tremor. Focused ultrasound is available and has been available as an advanced surgical technique that's available for tremor syndromes. It offers a minimally invasive option, and especially for those who otherwise might be hesitant about pursuing DBS or not easily qualifying for DBS surgery. And then heating prior to burning, that provides an opportunity to neuromodulate. We use that word a lot in our business, where neuromodulation, a way to affect the nervous system through trying to provide little hints of direction for the nervous system to change without having just one giant sweep or sweeping change at one shot. We can perform neuromodulation in focused ultrasound through the heating process and end with the burnt lesion that ultimately we want for effect. So to wrap up, one more time here, it's an opportunity for us to talk about our program. Dr. Krishna leads the effort with the focused ultrasound program at UNC, and we've built out this team-based approach, not only to the evaluation of patients with tremor for focused ultrasound, but in the procedure itself. Appreciate that opportunity to be together so that we can not just have his expertise with planning out the procedures and ultimately delivering the doses of ultrasound that we're looking for, but also to use examination maneuvers in the scanner where we can drive decisions of where to best burn the next area or to heat up the next area using additional exam components that otherwise might not be traditionally utilized, and that provides a lot of information that we have found quite useful to date in our program. We also have our first of its kind, and to my knowledge, still the only of its kind, tremor interdisciplinary clinic. You're seeing in one single sitting, one morning, a long morning, over 3 to 4 hours, multiple subspecialists who have practices in tremor management. This includes myself, includes Dr. Krishna, one of our tremor specialized occupational therapists, Melissa Collins, and then a host of other team members who assist us with quite a few extra pieces, whether it's coordination for research, biomedical data analysis for tremor through a biomedical engineering team, and our nurse educator. It's a great opportunity. It's one of our funnest opportunities every month where we get to collaborate and provide a meaningful, comprehensive review for our patients who walk through our door, with the hope that that's useful information that you could take back to your providers. This is a means of contacting us at our different clinics, but ultimately we end up communicating with each other so we can make sure everybody is seen by the appropriate host of folks. I think I will stop there. And should I unshare here, Mike?
Nope, you can leave that up. That's fine.
Okay. All right.
Well, thank you so much, Dr. Roque and Dr. Krishna, for this very insightful webinar. We did have a few questions. I'll read those out and let you guys pick who's going to do the answering. So the first question is, if a patient wanted to make an appointment, how soon would they be able to see you, and how long does it take to get the procedure?
So I think between the two of us, we can usually manage to start off that evaluation within a few weeks. And the second question was about how soon can the procedure be done? Is that?
No, how long does it take to have, once the procedure's done, how long does the procedure take?
The procedure itself. So the focused ultrasound procedure, as I alluded to, it's per side is going to be roughly a 2 to 3 hour, maybe 2.5 to 3.5 hour procedure. And that's from start to finish in terms of not the heating and burning itself, but just from start to finish. You coming in, getting your head shaved that day, and placing the frame and things of that nature. So, to when you get a chance to leave, that'll be the total time frame. Hopefully that answers that.
Mike, I wanted to add this to this as well. Dr. Roque and I have made ourselves available, and so the referral comes in, and we are open to seeing you. Whoever of us has the earlier availability, we see the patient and then refer appropriately to each other. Because at the end of the day, this is a collaborative effort where expertise, both from Dr. Roque and myself, is critical in making sure that you have the outcomes that are the best, and then that you're able to achieve tremor reduction to the fullest. And so that's the key. The second question was, Dr. Roque talked about the treatment time, and I would say that in terms of from the time when we see you to the time when we schedule the treatment, we try to keep it as short as we can. Usually you have to do a CT scan and an MRI. And so we have a team of coordinators, as you can see in the picture here. We don't have Kelsey in the picture, but we have Wes. Between Wes and Kelsey, they can help streamline your appointments so that you, within the least amount of appointments, you can get your CT scan and MRI and get the procedure scheduled. And so in general, what we are seeing is that it's within a few months and based on your availability that we are able to schedule the treatments.
Great, thank you very much. Another question. If I were to get focused ultrasound, how long will the symptoms stay away? And as a second part of that question, if my tremors come back, would I be able to get retreated?
Yeah, so mentioned earlier, it absolutely, so the longevity, we're still in this particular program going to be still keeping a keen eye on that. There is some data that starts off at around the 2-year mark, suggesting that folks may be losing some of the effect, some percentage. Perhaps more traditionally, what we talk about is with thalamotomies, 5 to 7 years, we might see a drop off, perhaps of as many as 50% of folks. Now, there is current data on focused ultrasound that is going out 5 years and saying plenty of folks still have a lot of tremor benefit. And it goes back to not quite knowing what are all the variables we need to be successful for longevity. But as we learn more, we're certainly, and I can tell you in our practice, we're doing everything we can to utilize the up-to-date information to drive the decisions of where best to burn the lesion, so that you could keep longevity for as many years as possible. The question of could you go back and perform the procedure again is, there are circumstances that would certainly allow you to do so. And it depends on how your first procedure went. So if it was successful and you really had no additional complications, barring something that might keep you from becoming a regular focused ultrasound candidate, the ability to perform a new procedure could very well be there for you. And Dr. Krishna, other thoughts that you had?
No, that's a great question. And so to build on what Dr. Roque just said, as you all know, this procedure has been around for a little less than 10 years. And so, the longest, at least that I have seen in my practice, is 7 years out from the treatment, and patients were able to keep their tremor benefit. But as we know more and more, and as we treat more and more patients, we would know the longevity of this treatment. And then certainly, there is an opportunity to go back in and redo the ablation. And so that shouldn't be a problem.
Great, thank you very much. We've had quite a few questions regarding medications for tremor, the standard questions or the standard medications. One is, will I still need medications after the treatment? And as a second part to that question, how long before the treatment would I need to discontinue my tremor medications?
So usually we wouldn't have folks truly discontinue their tremor medications before the procedure other than the day prior. And that's just so we could see the tremor perhaps at its greatest. And we do the same thing in deep brain stimulation surgery. We're just trying to get the tremor to be at a higher amplitude for purposes of seeing it, visualizing it in the procedure. Past that, the idea of coming off tremor medications. Well, if you have, as most folks do, a bilateral tremor, right after that first procedure, you're not going to want to come down and off your tremor medications just yet until you've at least had that second side done. Once the second side is done, it'll just depend back to how well did the procedure go for you. Like, how do you feel well enough that your tremor is really managed on both sides well enough to want to come off medications. We see the exact same thing in deep brain stimulation surgery, where folks get significant tremor reduction, and even though they get it, they still feel like the medication just takes the edge off of their tremor, since we didn't cure anything. So can we reduce how much medication you're taking? Sure, and that's perhaps more often the rule than the exception, as opposed to coming completely off medication. That would be more the exception than the rule. And it's going to depend on how you feel about residual tremor to help answer that question for you.
Great, thank you very much.
One
Go
more
ahead.
point I would add is that most of the reduction that we would see would be after treating both sides. So as you know, that we would treat both sides tremor, so right and left, and you know, depending on if the patient is left-handed, then we do left and right, left side first and then the right. And so once you treat one side, we wait about 9 months to a year between the two sides. And so during that intervening period, we are able to sometimes come down, but most of the medication reduction happens eventually when both sides are treated and patients have control on both sides of tremors.
It makes good sense. Thank you, Krishna. This just came in. I'm extremely claustrophobic, so I assume this is not something I could go through. Is this correct?
Yeah, I can certainly say, as I alluded to earlier, since we couldn't use, if you're claustrophobic to the point you really would require sedation to get into and out of an MRI scanner, which is a tight MRI scanner, to be fair, this might be quite difficult for you to pursue. And I'll let Dr. Krishna, because Dr. Krishna has the experience with folks who have had claustrophobia who maybe still went through the procedure. But in short, if you feel you would need sedation in order to get through an MRI scanner, we're going to be suppressing your clinical symptoms during the procedure, and that would be detrimental to your results. Dr. Krishna, because I know you have the...
So your point is very well taken, Dr. Roque. And so if you give medicines, most of the medicines that control claustrophobia end up in reducing your tremors. And so that works against us. And so that's why, as Dr. Roque advises, not to have medications prior to. The good news is that during this treatment, you are in and out of the MRI machine. And so the longest you are inside the MRI machine is roughly 7-8 minutes time period. And then we go in and do the testing and take you out. And so again, you know, if you are able to lay inside the MRI machine for the diagnostic MRI, then you should be able to do this procedure without difficulty. And in order to think about it, what we are doing here at UNC is that you get a chance to have an MRI in the same MRI magnet that we're going to be doing the treatment in, and then you go in and do a MRI machine ahead of time, and so that you can test whether you will be able to stay inside that MRI machine before we actually get you down for the treatment. And so something for you to keep in mind that you can try the diagnostic scan first, and if you're able to get the diagnostic scan, then you should be able to go through the treatment. But a great point that you raise, and certainly this is a keen issue that we are aware of and we asked during the candidacy assessment.
Thank you very much. A couple more questions, one on insurance.
Mike, can I sort of say one more thing here while we have Dr. His expertise here? One of the questions the patient asked is that they're taking what sounded like a moderately high dose of anti-tremor medicines. And their question is that they're starting to feel tired all the time. And so they wanted to know how much medication is too much.
Yeah, the short answer to that question is whatever you feel starts to induce a side effect for you. So I can quote numbers that are traditionally maximum numbers, and I'm happy to do that. But maximum numbers are relative for when we tend to see a plateau, a drop off of any additional meaningful benefit beyond what you've already received. And then beyond that, theoretically, you'd just be getting side effects instead of benefits. So, but it could be that you're on low to mid doses compared to that maximum dose, and you're still feeling the side effects. So it's always going to be a relative, whatever your maximum dose is going to be. There's some weight-based dosing for these things as well, but you know, in short, those max doses we often talk about, again, our generalized topics are going to be the primidone that's out there is 250 milligrams daily would be a typical max. Topamax typically would be a maximum dose of 150 to 200 milligrams, and propranolol up to 160 milligrams in a day. But again, these are relative maximum doses. where we just generally say above those doses, you're not going to see any additional benefits on your tremor.
Great, thank you so much, Dr. Roque. A couple more questions. One was on insurance. The question is, insurance denied due to procedure being quote unquote experimental. When can we expect that to change so the insurance will be covered, so that insurance will cover the procedure?
Yeah, so insurance reimbursement is a sometimes a sticky topic for a variety of the treatments that we do. So just for the sake of knowledge for everyone, focused ultrasound to treat essential tremor was FDA approved in 2016 and has been insurance approved, insurance reimbursed since 2019. And all the major insurance carriers, at least the ones that I have come across, now cover focused ultrasound to treat essential tremor, including TRICARE. And for the staged bilateral as well, so treating both sides in essential tremor is FDA approved and insurance reimbursed. Focused ultrasound for Parkinson's disease has been FDA approved since 2022. And as you know, there is a little gap between when the procedure is FDA approved to when it's insurance reimbursed. And this year was the first year when a major insurance carrier has started to cover focused ultrasound for Parkinson's disease as well. And so we expect that in the next few months, more and more insurance companies will provide the insurance coverage. And so this should be available for both essential tremor and Parkinson's disease and insurance reimbursed soon. For Medicare patients, we have treated several Medicare patients and without any difficulty, but sometimes different Medicare carriers can have some challenges. We know that Medicaid does not cover focused ultrasound, so there are little nuances to it. And we are happy to have you talk to the financial navigators at our place to discuss these nuances.
Absolutely. And I also wanted to add that InsightTech offers a patient advocacy program. So if your insurance does deny, we'll work directly with the UNC financial team to help get that insurance coverage for you. Another question came in. How many of these procedures have you performed? And what percent was successful versus having an adverse event?
So I can answer that. I was actually writing the answer to this question. So
okay.
Yeah, both Dr. Roque and I have expertise in treatment of essential tremor. And so among movement disorder interventions, we are very excited about taking care of patients with tremors and have the breadth of expertise in all different type of tremor treatments. And so between the two of us, probably we have done upwards of 400, 500 tremor operations. Personally, I've been involved in focused ultrasound since 2015. I've done over 100 focused ultrasound telemotomies for patients with essential tremor, and we have published our results widely. And overall, what we had published is that roughly 70% relief in tremor, and about 1 in 4 patients who have difficulty with imbalance. That's the most common side effect that we see after this treatment. And 1 in 4, most of these patients have temporary imbalance issues, which are in the first 1 to 2 weeks. And as the swelling around the ablation goes down, balance gets better. And I'll say that about 10% of patients, 1 in 10, may need physical therapy, outpatient physical therapy, to make sure that the balance is good. There is a very, very low risk of numbness, especially around the face or the fingertips. So I'd say I've seen a handful of patients with that. And I've seen 1 patient who had difficulty with weakness in the foot that took a few weeks to improve. And so those are the outcomes, and our outcomes are as good as anyone else in the country.
Great, thank you very much. Not really a question, but one participant said they just wanted to thank you for an excellent webinar, and not sure what they're going to do yet, but they're going to talk to their physician, and learned a lot today, and I agree. We had one more question, but I think we've already covered that. Is the procedure covered by Medicare? And I know we just covered that, and The short answer is yes, it is covered by. So I think that exhausts all the questions that we've had this afternoon. Dr. Krishna and Dr. Roque wanted to thank you for another excellent educational opportunity and sharing your expertise on focused ultrasound. So having said that,
thank you, Mike, for the great opportunity. We just want all the participants to know that we would continue this webinar. Both Dr. Roque and I received very positive feedback, and your questions and engagement has been very rewarding. And so we'll do the same set of webinars in the upcoming year as well. And so you will get to see some dates and some of these concepts. It's good to reinforce, and so certainly happy to reconnect with everyone when we relaunch this in July.
that sounds great. And if you'd like to make an appointment with Dr. Roque or Dr. Krishna, the information is on your screen. So take a quick snapshot with your camera or your smartphone. And thanks again for everyone for joining us this afternoon. And we hope everyone has a fantastic day.
Thank you, everyone.